I thought what I would plan for is to go through the video that I put together last year with the help of all the talented people at MacEwan on the ABI assessment procedure. Now that video, hopefully you've already reviewed it once or twice, but it's really going to be the benchmark for your assignment for this final video assignment or your return demo if you come in person at MacEwan. You're probably already starting to think about or you're starting to formulate your final video, and I just want to talk about some of the technical things you should consider when you're preparing for this. If you are creating a video, make sure that you have a volunteer and that you have all your equipment with you and that you block off a significant amount of time in your day. It's probably going to take about a half a day to do the recording, and you may want to do multiple takes, and you're going to want to maybe experiment with a quick upload of a very short clip video into YouTube. So just to relate my experience from this morning, I've already done this class twice. The first time I did it, my program didn't work. I'm using ScreenFlow, and I had to download an upgrade, and I did that, and then I lost the complete recording, so I had to start all over again from scratch. Then I tried it again and realized the sound wasn't working. So there's all kinds of things you need to experiment a little bit before you go ahead and do your final recording with your volunteer in place and all of your equipment. Just do an experiment or two, upload it into YouTube. You can send the link to me. I can have a look at it and make sure it's working from my end of things. One thing with YouTube is that you do have a file size limit. So your video is going to have to be quite concise, which is something I'm really wanting from you anyway. This whole vascular assessment shouldn't take you any longer. On a normal person, it shouldn't take you any longer than about a half an hour. I realize for this assignment that you want to show a few things. Like for example, I would like, if you can, a couple of close-up views of your angle and where you're finding your Doppler samples, where you're placing your blood pressure cuffs. So you may have to stop your recording and then bring your camera over so that you can show those close-up views, or do a bunch of close-up views at the end of your video. So those are a couple of ideas that you can explore. But anyway, as far as the file size goes, it probably shouldn't be any longer than about a half an hour or so. If you're coming into MacEwan to show your return demonstration, just remember that you'll have to set up an appointment with me. A couple people have got appointments set up, and you will have to bring your equipment or notify me in advance and I can have equipment there for you. Make sure that you bring a partner or a victim so that you can show me on a real person, and because you'll have to assess the Doppler flow. And that's about it for that. In light of all of the technical issues related to this course, I have put out a request to our administrators, first of all informing them of, the problems that we're, magnitude of the problems that we're having. I have been keeping them informed all along, but I really wanted to impress on them that it's now really encroaching in on our learning. And I've asked them for a blanket offer for extensions without charge to all of you. So if you do need a little bit of extra time with your final video projects, that'll be fine. I'm sure that they'll authorize that considering all of the problems that we're having. So what I think I'll start with is we're going to start with the video. And as we go through the video, I'm going to pause it and then just discuss a few things. So that'll be kind of the plan for the day. I'm hoping to cover the equipment and care of equipment, a couple of aspects that we're going to see in the video that I want to bring up, and just some general expectations of what I'm hoping that you'll be able to perform back to me. So okay, so I'm just going to go ahead and start with this video. Good morning, Mrs. Bolin.
Good morning. How are you today?
I'm very good. How are you today?
Good, thank you for asking.
My name is Megan Lehman. I'm the home care nurse, and I'm here to do an assessment on you. Your doctor probably talked to you about it.
Yes.
Okay, so just a quick note right off the bat. You notice the patient is already laying in bed, so we can assume, well, actually we can't assume that she has been resting for 15 minutes. And so we all know by now that the 15-minute rest period is to make sure that the patient is relaxed and warm, and that they are at a normal vasoreactive state for a rest period. So that should mean that she is vasoconstricted in her legs. If your patient hasn't been resting, then at that point you'll have to bring them into the room or put them on a stretcher wherever your location has to be, and they can sit up and rest for 15 minutes while you're gathering your equipment and taking your patient history. So that'll be the next part of the video.
You did, thank you.
Okay. Can I just set my bag on your chair here?
Certainly.
All right. So what I'm going to do is, first of all, I'm going to ask you a couple of questions about your history, medical history, your family medical history, and about your legs, of course, because I think that's why we're here. Is that right?
That's what I remember the doctor saying.
Having some pain in your legs? Okay. And as we're talking, I'm just going to be taking out my equipment that we're going to be using today. I will be using some ultrasound type of equipment. There's no pain involved with that, no risk to you in using this type of equipment, but it will be a little bit noisy. You'll hear some funny sounds as we go through the test, okay? All right. So tell me about your legs. Okay, so I'm going to pause here for a second. One of the things I always like to tell patients is the kind of energy that they're going to be exposed to. So I think later on in the video I go into it a little bit further, but usually what I like to do, especially patients who are very nervous about medical care, is I like to actually show them the equipment. You'd be surprised at how many people believe this to be a very sharp instrument and that you're poking them and hurting them. Really what it is this is the Doppler transducer, and the transducer emits a sound wave at a certain frequency out of one crystal at the end of this, and it goes into the skin of the patient and deep into their tissue, bounces off of moving red blood cells, and then it bounces back into the transducer into a different crystal. So there are two crystals at the end of this transducer. Now what happens when it bounces back in is because it bounces off of a moving target, so that's the red blood cell moving through the bloodstream, it comes back at a different frequency. So part of the Doppler formula is to subtract those two frequencies to become, with the delta being the frequency of movement of the blood cell. Now what that tells us is how fast the blood cell is moving through the bloodstream. And you know that throughout the cardiac cycle, it moves faster during systole, and then it decreases and decelerates during diastole. So that's where we get a nice little waveform. In essence, the sound energy goes into the patient, and there are no known bioeffects of sound energy going into the patients. Though in laboratory testing and so on, there have been some cavitation, and that's where cells will collapse in on themselves, but that's at a very high power, very, very high frequency type of ultrasound, and so generally not in medical diagnostic ultrasound. So the other aspect about this transducer is that it has a layer right at the very end called a matching layer. And what that does is it actually transmits easily the ultrasound wave right into the patient's body. Sound waves travel at different, what we call propagation speeds, in whatever medium it happens to be in. So if you were in a vacuum, like in outer space, there is no sound at all. It can't travel through a vacuum. It actually does require a medium. So in air, it has a certain propagation speed, and in water, it has another propagation speed. So you probably even notice the difference when you're underwater and you're trying to talk to somebody. the sound comes up differently, and you have to be facing directly at that person, like so that your ear rather is right at the firing of the sound wave. And in the body, there's a certain propagation speed, which is the same speed as water. So what we do is we have gel that we put at the end of this transducer so that it helps to transmit the sound wave into the body as a conduction. Versus if it hits air, it will just dissipate into the air and we'll lose that sound energy and we won't get a very good signal. We might get some kind of a signal because some sound waves may go into the body, but we'll lose quite a bit of it to the air because of the difference in propagation speeds. So that's a lot of technical talk, but it's really important for you to know kind of how this is built, in the sense that you need to look after it in a diligent sort of way. You'll have to, for example, keep it clean. I wouldn't use any alcohol or anything that's very drying on the edge of this because of the matching layer is fairly delicate. Keep in mind that these crystals can break easily, and one of the things you have to really watch out for is if you hit the crystal against something, you may lose functionality of this transducer. So you have to create some kinds of ways of monitoring damage to these. It could be quite elusive. It may just be a matter of when you go to use the transducer, you find it very frustrating obtaining a Doppler signal in a normal patient when you would expect it to be easy to find a Doppler signal. So in that case, you may have to question your equipment. A couple of ways you can troubleshoot it just at the workplace is try it on yourself. And try it on yourself a few times anyway, just to get a baseline. But if you are having trouble finding your own pulse when you know you're normal and you know that it should be easy to find, then you can start to question your equipment. Another thing that you can think about is if you have another piece of equipment, you can compare them side by side. Other than that, though, it may be a matter of sending it into the vendor themselves to do the testing or to replace the part. That will depend on your vendor agreement and your relationship with them. So that's probably something you'll have to explore at your end. So other than that, other than the Doppler, I should say, there is also the photoplethysmograph. Now the photoplethysmograph is just a tiny little probe like this. It also has a patient-facing side and a Velcro side. So of course this interface is what touches the patient. There are two diodes, just like I talked about with the Doppler transducer. There are two diodes at the end here, the one that constantly sends out an infrared signal and one that constantly receives an infrared signal. And it works very much the same way, where it calculates the speed generally and gives you a waveform, an arterial waveform. So that's how that works. I'm just going to pause for just one moment. For that pause, I just had to go grab my power cord so I can plug in my computer. So let's watch a little bit more of the video, and now you should be able to explain the energy that goes into your patient.
Thanks. What kind of pain are you having?
Well, I notice it a little bit when I walk, just this real achy pain, and then occasionally it goes shooting up and it's kind of warm. And
okay. Is it more in your muscles or in your knee? Is it in your joint or more in your muscles?
I think it's more in my muscles.
Okay. Yes. Okay.
Okay. So why do you think I'm asking this patient as to where her pain is versus her joints versus her muscle? What kind of pain is this? I'm just going to be putting out these questions as we go through. These are all things that you should definitely know.
That's what a lot of my patients talk about. And so about how far can you walk before you have to rest, do you find?
About 2 or 3 blocks.
Right, okay.
On a good day, it's 3 blocks.
Right, and then so when you sit down, does the pain go away?
It gets dull,
Okay.
and then I can go again for another 3 blocks.
Okay. Well, that's good. So you can make the pain go away, and then you can walk a little bit more.
Right.
Okay.